Great. Well, that's a great start. Thank you, Dr. Wong, for getting us started. So next I have the extreme pleasure and honor to introduce Dr. Soo Borson. Dr. Borson is the co-lead of the Bold Public Health Center of Excellence on Early Detection of Dementia and is professor of clinical family medicine at USC. She's also professor emerita of geriatric psychiatry at the University of Washington, and truly a pioneer in the field of early detection. Welcome, Dr. Borson.
Good morning, everybody. It's so amazing to see three-dimensional individuals. I spend my days on Zoom, and it's a pretty thin experience. So thank you all for being here, and thank you, Freddie, for including me in this conference. I think it's really a wonderful approach to state-of-the-art. So, the case for early recognition of dementia. I can't make that case. The reason I can't make the case is to make the case, you have to have really good data. And we don't have really good data. We have really good data that if you screen people, you can increase detection of dementia. That's incontrovertible. It's been shown by many different groups using many different kinds of tools for detection. But what we don't have is what the U.S. Preventive Services Task Force wants, which is proof that if you do systematic early detection of dementia, you can increase or improve the outcomes for patients, for families, and improve decision-making by clinicians. We all know it's true. We know it's true. Those of us who care for people with dementia know the good that we do. But proving the good that we do and linking that to early detection is a whole other thing. So that's why I can't really make the case. I can advocate for it, but and I think all of us do that. But let's take a walk through some of the thinking that I've been doing over the last number of years and try to bring it together and conclude with a sense of what it is that we're trying to accomplish for people. It does require a change in the way that we tend to approach care. In medicine in particular, we focus on disease. We still do that. In spite of the movement to make care person-centered, and this is an enormously valuable and important movement, we still think about one disease, we're detecting dementia. Well, what about the rest of the person? And so you'll see as we go through this that there's a lot more that we need to think about if we want to promote early detection on a population scale. So my objectives are to identify key barriers to early detection of cognitive impairment within health systems, recognize the beliefs that impede early detection among medical providers and other healthcare professionals, describe how early detection can help patients, families, and clinicians, even if we can't exactly prove it. So I'm showing you a slide from Florida Department of Public Health. Why? Because where are people who live with dementia? They're everywhere. They're in all of these sectors. They're where people are. People with dementia exist where people are. And so detection is really everybody's job. But as a physician, I know best the role of physicians in healthcare systems, and of course I'm naturally going to gravitate toward talking about that. And there's another reason, and that is that it's very recent that detection of dementia has started to occur outside of healthcare systems. I'll give you a quick example. One example comes from the state of Georgia, which has an award from CDC to improve early detection of dementia and develop a care model. Well, this is a public health department, so these are not clinicians. What they've done is train public health workers to screen people for dementia wherever they're found, and then to take that information, give it to the people, and get that information to a clinician. And from there, it goes to a diagnostic evaluation, and then it goes into a dementia registry for the state of Georgia. Now I'm speaking a little ahead of what they've actually completed. They're still in the midst of their work, but that's their goal. And there are a couple of other states that are doing very similar kinds of work, starting with public health workers. So I approach dementia, as I said, because I'm a physician, I approach it as a medical problem, but we recognize that its manifestations are mostly social and behavioral. Physical manifestations of dementia per se are limited to late-stage dementia when people can no longer move around. So if it's a medical problem, who's doing the medical care? This slide shows in red the trajectory of dementia. Now, this is a pretty old slide, but it still holds true. I don't think anything much has changed. There's an exponential rise in the number of people with dementia. This is an Alzheimer number. If you include all the dementias, it's going to be higher than that, but you see the exponential rise. What about the specialists? Like me, I'm a geriatric psychiatrist. We have a geriatrician in the audience, more than one. And there are neurologists. There are very few cognitive neurologists. And when you look at geriatric psych and geriatric medicine, you see down below in the purple and blue dotted lines that the numbers of these specialists are not increasing. They have not increased, and they are not increasing. For geriatric psychiatry, there are about, my understanding now is there are no more than 50 people training in geriatric psychiatry in the country. That's less than one per state. Wow, okay, so that has some pretty big implications, right? It's that primary care is primary. It has to be. So primary care providers make 85% of first diagnoses, and they provide 80% of the medical care thereafter. Primary care doctors who like doing dementia care say, we do it all, birth to death. We like to do it. We like taking care of people with dementia. Our job is to have a continuous relationship with our patients and take care of them no matter what. However, late dementia, detecting dementia at moderate and severe stages remains all too common. And overall, we still are stuck with about 50% detection rates. This hasn't budged. Just like the number of specialists hasn't increased, the rate of dementia detection hasn't really increased either, outside of very specialized environments. And the care framework for dementia within primary care is very badly underdeveloped. You'll see that I'll spend a fair amount of time on that later on in the talk. How about memory disorder specialists? So we're talking cognitive neurologists, geriatric psych, neuropsychologists, but mostly on the medical side. They only make 15% of first diagnoses, and they provide less than 10% of all the care. So some of you have heard this, a little bit ugly, but nevertheless illustrative idea. Diagnose and adios. Come to our memory center, we'll tell you what's wrong with you, and we'll send you back to primary care. Goodbye. Well, we're changing that slowly. But there are access issues. People are waiting a year to be seen by a specialist in many, many places. Just to put a little fine point on it, when I was at University of Washington, it didn't matter how many staff I hired. We could never get our wait list down. It just kept growing and growing. That's a really big problem. Also, specialists do tend to focus on disease rather than whole person care. Not all, but many. And there's a variable relationship with primary care. So there is no one set model within a large healthcare system, say, about how a geriatrician should work with primary care, how a neurologist should work with primary care, or a psychiatrist. And generally speaking, in most healthcare systems, the specialty roles are really kind of isolated and insulated. So these are kind of the landscape as we live it today. I want to talk about health system barriers because early detection of dementia, if it's going to lead to diagnosis, we have to be thinking in terms of health systems. And 6 Ps, I like models. I like multi-domain models. You'll see more of that in a bit too. Let's talk about prevalence. So what are the health system barriers, the 6 Ps? The first is prevalence. The prevalence of dementia is only about 10 to 15% in older adults. That's not a lot. Big numbers, but not a high percentage. Compare that with COPD. COPD prevalence rates are about 5%. So dementia is a lot more popular than COPD, but it's a very small fraction of the overall patient population in a large healthcare system. So kind of an invisible group. How about payment, second P? CMS, was founded to pay for disease-focused, body-focused treatment in individuals and for time-limited episodes of care. CMS models for chronic disease management aren't really very well developed. Pricing. Reimbursement is too low for dementia care done right, period. Professional boundaries. It's hard to mix psychosocial and medical care in the same place. We have our silos. It doesn't work well in our system, and that has everything to do with our payment models. Priorities. Priorities favor the required quality metrics, and there aren't any for dementia. What do I mean by that? Health systems have to report certain quality measures to the government to receive government money in payment for services. So if there's no quality measures that are required or reportable for dementia, we're kind of stuck. There are some quality measures for dementia, but they're not system-based. They're clinician-based. And they're rarely used. These are quality measures for dementia care. They tend to be used mainly by neurologists, if used at all, and mostly aren't used. They're a good set, but they're not used. Then finally, prevention. There's a lot we can do to prevent, and you heard a lot about what we should be doing for primary prevention, preventing cognitive decline. But we have a ton of secondary and tertiary prevention, doing better care for our patients who already have dementia. But our systems don't recognize those opportunities in a very systematic way and don't back them as a policy. Let's turn to beliefs. There are a lot of beliefs. Many of them come under the rubric of stigma, but let's just dig a little deeper into clinician beliefs, patient and family beliefs, and recognize that some of these beliefs are false and some of them are true. Doctors often say, "Why should I detect dementia? There's nothing I can do." And the answer to that is, boy, you really don't know what you can do you? It's so much less about what you're doing with your prescription pad, so much less than what you're doing with your advising, and it's everything to do with the relationship that you have with the patient and their family and how you maintain that relationship over time. The healing power of that relationship is badly underestimated by physicians, really badly. There's also the commonly cited problem of, I don't know how to do it, I didn't learn about it in training, I don't understand dementia, and what if I make a mistake and I'm embarrassed? I know my patient needs help, their family needs help, and I need help, and I want to help, but I can't do it alone. There we have our common primary care setup, which is a doctor with a panel of patients with very patchy support systems for that practice. Well, how about patients? I don't want to know. I'm going to be a vegetable anyway. Don't tell me about it. There's nothing really wrong with me. I'm just going to try harder. I feel so stupid. You're going to take away my driver's license or put me in a home. You can't make me. I might as well die. Now, that's an exaggeration, but there's a lot of reality to it also. How about families? I don't know what I'm seeing. I think it's just aging. That accident he had, I don't know. I mean, couldn't that just happen to anybody? I don't know what I'm seeing. I don't know, he's a little different, but I don't know what this is. Well, she won't go to the doctor anyway. And so, summing that up, how do I know when it's really something rather than just nothing? Or he'll be furious if I bring it up. He won't talk to me, or he'll blame me for it. We've all heard these. Then community-based service professionals, and this, of course, is conditioned by the services being provided in a given organization. Dementia as a diagnosis doesn't get you anywhere in getting community-based services. Functional disability gets you eligibility. But typically our community-based publicly funded services depend on levels of functional disability that are characteristic of later stage dementia, not early stage dementia. All dementia is disabling. Dementia isn't dementia without disability. Let's pause on that for a minute, because we tend to conflate biomarkers and Alzheimer's disease and dementia and put it all together in one bucket, and it's not a bucket. Here in this talk, I'm talking about dementia, which is an acquired cognitive impairment due to disease or injury that causes disability at some level in everyday life. Cognitive impairment without disability is not dementia. So let's be clear about that. So to not be disabled enough to get services, that isn't limited to dementia. Many people with disabilities have found themselves on the outside of services too for the same reason. Then there's the problem of silos. We in community services don't really connect with healthcare at all. I send my reports to the doctor, but I never hear anything back. They don't really seem to know or care what I do. They don't think what I do requires skill. And after all, isn't healthcare really rich? Well, we're understaffed, underfunded, and underappreciated. So I've given you exaggerated versions of the barriers that have to do with attitudes across the entire spectrum of those of us who want to help. This slide is thanks to Dementia Care Aware and permission to use it and adapt it. So really all this shows is, look at the red on the right. The red on the right is moderate and severe dementia. This is where dementia detection is happening today. You know, somewhere almost a half of people with dementia in the Kaiser Southern California system who have a diagnosis of dementia in their medical record, almost half of those were first diagnosed in their 80s during a hospital stay for some other condition. A point at which in their dementia trajectory and their life trajectory, not very much is likely to be doable for them besides helping them to be comfortable. So we think about, wow, if that's the state of the art. And elsewhere in other studies, it's about moderate stage is the average place. This isn't necessarily all wrong either. Why? Because it's at that point where you're moving from mild to moderate dementia that cognitive problems begin to manifest in functional disability to such a degree that families are saying, help. So there's a good reason why we delay detection at that point, but we're trying to move it earlier so that we can engage in preventive interventions for patients and families. And we can. We can detect dementia processes at much earlier stages using the tools that we actually have. So we can. So here, this is a slide that I borrowed from David Rubin at UCLA. This is data from, I think, around 2015 in UCLA. They were looking at how many people exist in the system who have a diagnosis of dementia. What do they look like? So at the bottom, you see there are fifth tier and fourth tier. This is in all stretches, the largest population of people with dementia are there at the very mild stage. Some of them are getting primary care and other health care, some are not. But that's the largest group. Then way up at the top, you know, in that top triangle there, the first tier, that's only about 50 patients of all of these. They're the really expensive ones. They're the ones who have multiple hospitalizations, they stay a long time, they're terribly, terribly sick, they don't do well. And that's the image that we've had of what dementia does. But look down at the bottom again. Today's topic is about early detection. And this is where we want to be working. We want to be working at the level of the population, where the largest number of people are who have dementia, but whose illness is relatively mild, and who don't have a ton of comorbid conditions. Not yet. Okay. So to try to persuade health systems to make changes in this, some of us thought that understanding the health consequences of dementia would be influential. And what are they? Well, you'll see, I'm just going to run through a whole bunch of them that we know are real. Complications in families, poor chronic disease control, you name it, death, surgical complications. We know that, and it has been surprisingly non-influential in healthcare systems. Nobody seems to really want to tackle that problem from a systemic point of view yet. And part of the reason, maybe the great majority of that reason, is because dementia is harder to manage than diabetes or heart disease. It just is. It's a lot more complicated. Appropriate care pathways need to be developed, created, and embedded in primary care. And about half of patients are over 80, and that has implications too. They have other age-related issues. Multimorbidity is the norm. So looking at the National Alzheimer Coordinating Center data that a student of mine during her PhD work, she examined comorbidity and found that 90% of people enrolled in Alzheimer's disease centers nationwide had at least one other chronic medical condition. Over 25% had 3 or more chronic conditions, and over 85% had at least one emotional or behavioral problem. So we've got the comorbidities, we've got emotion and behavior, and we begin to see in the data the complexity that we're wrestling with. We see it in preventable hospitalizations. We heard in the previous talk that the lowest percentage of excess hospitalizations reported in the literature for people with dementia came from a study that we did at Group Health Cooperative in Seattle. 40% excess preventable hospitalizations compared to people without dementia. We really have to do better than that. So how? Early detection and diagnosis before a crisis. If there's one thing I hope you'll take away today, it's that our goal is what I call no crisis care. We want to prevent crises in dementia care. It'd be great to prevent dementia, but we've got dementia in our population, so what should we do? We should orient ourselves around preventing crises. We should immediately engage care partners. Detection should immediately be followed by engagement of a care partner. Some of you will say, well, not everybody has one. I know. But most people have somebody. So let's stick with that for now. Then do an individualized risk and needs assessment for patient and partner. And develop a comprehensive care plan to manage those risks. You have to identify the risks to manage them. And then formal collaboration agreements and simple paths for connecting sectors of care, healthcare to community care, specialty to primary, an organized system of care, which I think we would all like to see. Then planned and regular and systematic follow-up with flexible staff participation. I'm going to show you a model in a minute that is adaptable for many different kinds of staffing patterns. It is complicated, but many kinds of staff can fill the different roles within that model. We also have been developing virtual teams and will be doing that in perpetuity, I think. Finally, flexible modes of delivery, in person, online, in groups. The most fun I ever had doing dementia care was running dementia care groups with 6 dyads, a patient and a primary caregiver, 6 of them in a room together once a month, talking about themselves, socializing, sharing the benefits of a support group with the benefits of regular medical follow-up to be alert and observant for potential complications and emerging problems. So proactive medical psychosocial care done in groups. Really fun. I'd love to do more of it. So I promised the model, and here it is. This is the model. It's complicated, yeah, but let's break it down a bit. Okay, so look in the center. The care plan, we're focused here on the care plan for a person and their immediate caring network. It might be one person, it might be several people. Then let's start with cognitive health and function, which is light blue up on the upper left. Cognitive health and function, that's what gets us in. So cognitive function is about cognitive assessment, intellectual functioning. It's also about everyday functioning with in activities that require cognitive abilities like using the phone, going shopping, making a meal, and so on and so forth. The higher order cognitively relevant ADLs, IADLs. What is the diagnosis? That all goes in there too. But where is that person on cognition? Then moving to the right, emotional and behavioral health. That's the next domain. The third domain is physical health and function. And the physical, it's huge when you actually look at the patients. It has the most data elements in it. It's diseases, it's medications, it's other therapies, it's frailty, it's fall risk, it's sensory impairments. All of that falls right into physical health and function. The next, care partner capacity and needs. Caregiver stress, caregiver depression, caregiver support, caregiver backup, caregiver health and well-being, okay? The next, health-related social needs, what is usually referred to as SDOH or social determinants of health. I prefer the idea of health-related social needs because it's need-based. It doesn't start in childhood as a social determinant. It's actually now. What does the patient need now in terms of what are the social needs that would improve their ability to get healthier? And then the sixth domain over on the far left is the care delivery framework. Now, this one has to do with the fact that we're developing so many different models of care, and there are so many different places that where people with dementia are cared for. So the environment in which they are receiving care and the care delivery framework that surrounds them is another element. Now, why these six? It's a lot, but why these six? They were chosen specifically for two reasons. One is that they had everything to do with what I learned about how to do dementia care. I learned how to do dementia care by doing dementia care, by running a clinic, seeing patients, trying to figure out what was going on, listening to what they were telling me and what they were showing me. And I realized that all of these domains actually have a huge role to play, and they were things I needed to attend to in clinical practice and needed to teach about. Then it turns out that there are good data that support most of these. 5 of these, of the 6, are now validated through the acquisition of data about acute care use in medical settings. So each of these has its own contribution to make to unplanned acute care use, emergency room use, hospitalizations, unplanned hospitalizations, and emergency care. And if we're beginning to think in terms of no crisis care, then we need a framework for crisis prevention. And crisis prevention occurs in each of these domains. So that's the model that I am working with now as I try to think about what would I want to see in 20 years. It's certainly not going to be tomorrow. In 20 years, I'm going to be 100. I'm probably going to be dead. But if I am alive, if I am 100 and still able to think, then maybe we'll see some of this in practice and maybe even sooner. Now let's look at those funny little circles that are around the outside. Level 1, level 2, and level 3. These were developed for a curriculum for RN students, actually. But when I think about it, it works for everybody. Level 1 is problem detection. You can think of it as signal detection. There's a problem here somewhere, right? So for each of these 6 domains, there are very simple ways of doing problem detection. It's not a heavy lift. Let's just take care partner capacity and needs. How about a single item stress question? How stressed are you right now? Not necessarily how stressed are you from caregiving, but how stressed are you, since our stress comes from lots of places. That's an example of a really simple tool for populating level 1 problem detection. And I won't go into detail about how you might populate with simple tools all the rest of these 6 domains, but it's possible to do, and it can be tailored to the setting. So detecting problems across these domains is step 1, level 1. Level 2, detailed assessment. Once you have a signal detected, and I think of, some of you have heard of the mini-cog. I think of the mini-cog as a signal detection device. That's what it is. It correlates really well with dementia diagnosis and predicts a lot of important outcomes in dementia, but it's a signal detection device. It is not a detailed evaluation. So level 2 would be a detailed evaluation of cognition. And in most systems today, that would probably look like the MOCA. Although we could argue about that, and maybe we will later today. Then level 3, the most advanced, is care management. So care management, detailed assessment, problem detection, all of these are covered by Medicare in one way or another in fee-for-service practice settings. Traditional Medicare gives you opportunities to do each of these things and get paid to do it, but we aren't, not enough. So levels give you time. What does that mean? It means that you've got time to work with the person. You don't have to get it all done. It's rarely urgent to do this all at one time, all in one visit. You really can't do it very well that way. It's too hard on everybody. Breaking it down into domains, that gives you some space to think about, stepping back and what's overall, what does my patient need? And the model itself gives you a way to organize your own thinking. I don't know about you guys, but we in medicine have difficulty keeping track a lot. Being able to think clearly. How do we prepare for a patient visit when we have 1 minute and we don't exactly remember everything about that person that we saw last month? Well, if you have a model in mind like this, it gives you an opportunity to track the various problems your patient might have over time. Okay, so patient-centered targets for high-quality care, preventing crises. I'm going to just run through these really quickly. They're all there. These are all evidence-based targets. They're all things we'd like to reduce or fix and haven't yet succeeded in doing on a system-wide basis. So if we aim for no crisis care, we do know what to do. And we do know how, but we don't. So the idea behind today is to get us all activated to perhaps think about how can we do more of this. That's what our BOLD Center is all about. The BOLD Public Health Center of Excellence on Early Detection of Dementia is a part of the CDC's national legislatively supported effort to bring a public health perspective to detection, prevention, and caregiving across the nation using short-term, meaning a few years of funding for states or counties or cities, or for 3 centers, one of which I co-lead, the Early Detection Center. We have 5 years of funding. We're entering our 3rd year now. So what are we all about? So here's our message, that dementia is a manageable chronic condition. Detect it early before there's a crisis. Manage it proactively, follow simple proven principles, center on the relationship with the patient and the family, and work as a team. That's our message, that's our goal. Our mission is to make early detection of dementia a routine part of practice across the United States. Small goal. To make evidence about early detection tools and strategies available to anyone who can use them, and to discover and co-create solutions with stakeholders and communities. To promote implementation of effective and sustainable public health, clinical, and community initiatives focused on improving early detection, reducing stigma, and advancing health equity. You see, I'm waving my hands because this is the goal that we've had for decades now. The thing that's different is that we have federal funding for the very first time to try to accomplish some of these things in a more effective way. Finally, our mission is to empower individuals and groups to create pathways from detection to evidence-based care. How do we do it? We simplify. We have 4 simple steps to detecting cognitive impairment and clinical pathway development. We share real-world examples. We just came off a national symposium in which a number of really lovely examples of successful strategies for early detection were showcased. We amplify the voices of those who are having success and the voices of those who need. We highlight innovative early detection work and actionable efforts that might be adapted to diverse settings. And we seek to disseminate, to spread information about evidence-based practices and strategies to increase early detection. And provide technical assistance to support capacity building, decision-making, and strategic planning. And I can tell you now that the technical assistance we provide as a center is completely bound up with the technical learnings that we have from all the partners who are doing great work out in the field. So it's too late to sign up for our symposium because it's over, but when I made these slides, it wasn't. And then sign up for Dementia Care Aware training, which you're going to hear more about later today. So our goal is to be a lighthouse, and I hope that if you can take home one piece of light from today, it's aim for no crisis care, and think about how you can make that real. Thank you. We are ahead of time. We have time. I wonder if anybody wants to share an experience or tear down some of the things that you've heard. Say, why can't we? Yeah, go ahead.
Could you hold on a second, please?
I could definitely share a personal experience I have with my mom and dad. My dad is blind, had a stroke,
Could you just pull your mask down enough so we can really hear you? Thank you.
You guys hear me? Oh, there you go.
Much better, thank you.
Now that I can share my mom and dad. My dad had a stroke. He has glaucoma. He can't see. So physically, he's tearing down. You know, he's 77. My mom, on the other hand, she's completely healthy, takes vitamins, but her mind, we started detecting the early dementia. And
Take your time.
it's really hard for me to take care of my mom
Yeah.
because her mind is not all there. I can trust my dad to take his medicines on time, to not overdose. But for my mom, it's totally different.
That's right.
You know, my mom, she's all there. Her eyesight is all there. But yet she can't take care of herself. Mm-hmm. If it wasn't for my dad, I don't know what I can do with my mom. We applied for help. My dad was able to qualify for a lot of hours for someone to come and take care of him. But for my mom, she got a lot less hours because she can still do a lot of things on her own, but her mind is not there.
Right.
So I'm grateful that my dad is still there with us. He just got detected with cancer, but he's still doing okay. But I'm glad that he's there because he can take care of mom.
So you put a personal, very painful experience that's still ongoing.
Yes.
That's an illustration of a policy problem, isn't it? That's
Yes.
one of the policy problems that I tried to highlight, which
Yes.
is that in dementia, the disability is not visible.
Exactly.
And you get services when it is visible,
Right.
like your dad.
Right.
But when it isn't visible and it's cognitive, and yet you're so dependent on someone else, it's very difficult to get to qualify for services. And that is a policy change that some of us who are working with LA County on policy, developing new policy, that's one of the things that we're recommending. You know, CalAIM has its new expanded care management eligibility program, but dementia's not in there. It isn't called out as a problem, and it should be there.
Yeah, I
And
think so
we're
too.
we're really, this is an advocacy role, but I'm sharing it with you all because wherever you may have opportunities to talk about it, you know, it's the dividing line between physical and cognitive and mental disability that it's a real sticking point in our policy. I'm sorry for the struggles that you have, and I'm sure there are people here who would be happy to talk with you more about it.
I'm definitely managing it well, I think. Because like I said, we have help now, thanks to my dad. And she did qualify for some hours too, but so far it's been okay, it's been good. But yeah, I'm definitely glad you pointed it out, how hard it is for them to qualify for anything, because they don't, you know, physically she's well,
Yeah.
but
Yeah.
her mind is not all there. So,
Right, right. Well, thank you for sharing this.
No, you're welcome.
It's a universal story of struggle, really, for, I think, all of us in the room we know these struggles very well, either personally or professionally. Other comments or insights? Okay.
Sue, thank you for such a wonderful presentation. I'm Jennifer Schlesinger from Alzheimer's LA, and my question is, through CalAIM, the state of California now has a quality measure that they have adopted, which is the percentage of people 65 and older who have cognition assessed. Can you speak to what that opportunity is for our state and how we can operationalize that quality measure?
Well, that's a question. I mean, quality measures they live in the limbo of proposals, right? So that's another, it's another quasi-policy problem, which is where do we get data from? What are our data sources for understanding current patterns of practice? Most of this comes from healthcare systems. It resides within healthcare delivery systems. If you want to know, and healthcare delivery systems actually don't collect data about cognitive assessment at all. And most of them do not include results of cognitive assessments in electronic medical records where you can find them. So that's an issue. So we need to beef that, you know, to operationalize that. We need to get cognitive measures. Whatever the measures are that are approved within a given system, they can be harmonized across systems. They don't all have to be the same tools, but they have to be available and retrievable from electronic health records, number one. And not just embedded somewhere in a clinical note that requires a lot of staff and a lot of people to find the information. So that, I mean, to me, that's the thing that needs to happen next, because we're not going to find it very easily without reference to healthcare system data. You can ask people. I mean, Julie Zissimopoulos from USC Schaefer Center did ask a panel of people about whether they had had an annual wellness visit, say. This is a standing panel for research. Had they had an annual wellness visit, yes or no? If they had a wellness visit, did they have cognition assessed? Did they have any other cognition assessment besides that? And the answer was a lot of them just didn't have a cognitive assessment. Those who had a wellness visit said, no, I didn't really have that. And so you can get data like that from people through surveys. And I think by combining, for me, the greatest power comes from combining actual health system data with structured fields with survey data in the same population. While we're talking about electronic health records, let's talk for a minute about caregivers. Do we know who a caregiver is for any of our patients? Well, I do. As a clinician, I know because I sit with them. But can I find that person? When I go to my patient's medical record, can I find who's their primary caregiver at home? I can find their durable power of attorney if there is one. I can find the financially responsible party who's supposed to pay the bills for their health care, but I can't find the caregiver, the one who's actually enacting care and health care at home. Can't find that person. So that's another policy issue, and it's a reform issue for healthcare delivery. that is something that we are also wanting to promote through Los Angeles County and statewide. Do you have any other comments about how that percentage is proposed to be collected besides this way? And I think this will be the last comment, because then we're done with.
I mean, I think this
time
is
for
a
break.
really robust conversation that has to be had, and also how the state defines assessment, whether it's screening or it's actual assessment. From what we heard, it is screening, which I think presents even more challenges around documentation versus assessment. We would at least be able to pull ICD-10 codes to see if a diagnosis has been rendered.
Right.
So I think the state needs to clarify better what they mean by assessment of cognition, because that will then possibly dictate whether there needs to be a secondary or a future quality measure. If measure one is on screening, I would think later on you would want something around detection and diagnosis as well. But I'm curious if you feel otherwise. Is
No,
a
I
screening
think that's right.
quality measure sufficient?
It's how I think about it. I think about the signal detection piece. We didn't get into that in detail. We can talk more about it. I'll have some other ideas to share. But then there's the actual diagnostic evaluation and arriving at a diagnosis or no diagnosis. And then the final is, how do we even measure care? And so without that, we need the care measurements, and that's why I propose this 6-part model, because I think if we don't have those, and they're all those domains are intimately tied to the need to use healthcare and social services, then we don't have a robust enough data system. And we don't. This is where we are today. And thank you all for your attention and letting me speak. It was my pleasure.